everybody. I'm Jin. I was one of the fellows, and I was like you guys last year in our first boot camp that included anesthesia fellows. So TE for prosthetic valves. I'm going to go real basic for this talk here because I realize that a lot of you guys are either in your first month of training, you did like a couple of months of echo as a resident. I know I did when I was a resident. And as a fellow, you kind of have to like learn a lot really quickly because they expect you to know everything. And also for the cardiac surgery fellows out there, I know you guys are looking at the echo images kind of by memorization, and maybe you guys have seen a couple of pictures, but on top of that, you guys have to learn how to do surgery. So it's very daunting to like learn everything. I can imagine as a surgeon. So echocardiography is more difficult to perform on prosthetic valves versus native valves because there are artificial components of prosthetic valves that ultrasound may not penetrate. So by design, a lot of these valves also have regurgitation, and it's important to differentiate what's normal and what's abnormal. TE is a very powerful diagnostic tool for prosthetic valves. In fact, this is a paper that was written in 2009, and much of my topic is from this paper. And I encourage you guys to go home and download this and read it in its entirety. It's about 45 pages long, so you have a whole year to read this, so you guys should have no excuse after the end of the year. And it's written by a couple of people in our institution, Bill Zogby, and I think I see Miguel Quinones. I've never met them before, but you know, I'm sure I'll meet them. And really, these are the recommendations from the American Society of Echocardiography. So there are 3 scenarios in which you would look at a prosthetic valve, right? One is you're doing a native valve replacement, and after you fix it and you go off pump, you're looking at the valve, and you're going to say, surgeon, it's good or it's bad or whatever. You know, the gradient is, you know, whatever. Other reasons why you would do a echo exam on a prosthetic valve is for patients who have a prosthetic valve and you are doing you're doing unrelated cardiac surgery most of the time. Very rarely do you have those patients that are getting non-cardiac surgery, but for whatever reason, the cardiologist wants you to put down an echo probe and look at it. So, you know, you have that in our practice as well. And finally, you have redo valve surgery, in which you have a diagnosis of a dysfunctional prosthetic valve, and you put down the TE in the operating room to confirm that diagnosis. So we're going to look at some echo images. So this is for you guys who don't know, I've never seen this before, and I've never seen this in real life either. This is a cage ball or Starr-Everts valve, this is. So whenever you're looking at an echo image, you start off with where it is in the body. So this is mid-esophageal, and you say what kind of view it is. So this looks like this is probably a 4-chamber view, although I don't have the actual echo probe in my hands. And you can see the characteristic flow going around the ball during opening, and then as it closes, you can see a whiff of regurgitation. But the classic cage ball echo finding is that there's no washing jet. So what a washing jet is regurgitant jets going, that's made in, that's a function of the valve to make sure that, you know, to decrease the risk of thrombi. So in a cage ball, there's no washing jets. So that's the main thing with that. The tilting disc, there's one big orifice and one small orifice, and flow goes mainly through here, but some through here. The Medtronic Hall valve is the most recent single tilting disc, although I don't know how many we are putting in these days because most of them are bi-leaflet. But the main thing with those is that there's one washing jet going down the middle and a couple through the sides. So that's a single tilting disc, okay? So bi-leaflet mechanical valves are the ones that are placed most. I know Dr. Rule kind of went over that. And you can pretty much see that there's 2 big orifices and 1 small orifice going down the middle. And you'll see washing jets that go all around the valve, and that's normal. And depending on the valve, you'll see washing jets either converging in the middle, going to the outside, and it all depends on what the valve, what valve it is. So if you really want to get into it, you can look at the actual valve and talk to the reps and things like that and find out what the jets will look like. Yeah. So moving on to bioprosthetics, there are 3 different kinds: stented, stentless, and percutaneous, right? So the stented valve has a sewing ring that's mainly made out of Dacron and has usually bovine pericardium for the most part. And you can see here that the sewing ring causes shadow artifact over here. Sometimes it could cause specular reflection up here. So that is one of the challenges with the bioprosthetics. It doesn't cause as much shadowing as a mechanical valve, but it does cause some. And sometimes, so for the most part, bioprosthetics don't have a washing jet, but they do. Sometimes, some of them are designed to have a small opening in the middle that causes a little bit of regurgitation. So it depends on what valve you're placing there. Percutaneous valves are somewhat more difficult to image also because they have a metal cage that keeps the valve in place. So that can sometimes cause artifact down here. And you can see kind of down here, my images aren't working so great, so you just have to use your imagination. Finally, xenografts or homografts, they're tissue valves, so these are the easiest to image and they don't cause a lot of artifact. So these are the questions that you should ask yourself every time when you're looking at a valve. So if you haven't paid attention at all to this talk, this is really one of the key slides here, okay? So 6 questions you ask yourself. Is this valve well seated? So is it in a good place? Is it not moving around, kind of thing? If the valve is rocking back and forth, obviously that's bad because the ring can be dehisced, something like that, okay? So take a look at the valve, make sure that's seated well. Are the leaflets opening and closing normally? Sometimes you'll have a mass that's sitting on one of the leaflets and it's not open completely. And then you would have prosthetic valve stenosis. So that can happen. So make sure you inspect the leaflets. Check if there's any mass on the ring or the leaflets. So if you have endocarditis, you can have something on the leaflets or on the ring. And taking your time and looking at these valves is key to seeing these things because sometimes they can be very small and they could be moving very quickly. So that can be hard. Perivalvular leaks are always not normal. Transvalvular regurgitation, you can pretty much look at a valve and say, what's a washing jet, what's abnormal? You have to make that determination. Is there evidence of prosthetic valve stenosis? And what we'll do is that we'll shoot a Doppler through the valve itself and come up with a gradient and effective orifice area, things like that, to make a determination on that. And finally, a good echocardiographer will look at everything else in the heart and make sure that nothing else is involved. So what we have here is, let's just ask ourselves these questions again. So is this valve well seated? Yes, this valve is not moving around, it's kind of staying in place, so that's good. Okay, are the leaflets opening and closing normally? If this picture was going on a loop, you could tell that it's going back and forth and it's being okay. Unfortunately, these slides aren't working so great, so I apologize for that. There's no mass on the sewing ring. So you would take your time looking at everything. There's no paravalvular leak. You can see the washing jets, so there's expected transvalvular regurgitation, and finally you would look at a Doppler and evaluate for stenosis and look at everything else. So on to how to diagnose stenosis. You look at the effective orifice area. How do you calculate that is you get the cross-sectional area of the LVOT and you multiply that by the velocity time integral of the LVOT and you divide that by the velocity through the prosthesis. You can also do what they call a Doppler velocity index, which is the velocity of the LVOT divided by the velocity through the valve. Keep in mind that whenever you are doing a calculation with the cross-sectional area, so if you screw up on your radius at all, you're going to square your mistakes, right? So always keep that in mind when you're doing these things like effective orifice area, or if you're doing an aortic valve area with the continuity equation, because that's a very easy way to screw up or over or underestimate your areas. So from that paper from 2009, you can see that there are criteria for what's normal, what's possible stenosis, and what's significant stenosis. So peak gradient has peak velocity of greater than 4, mean gradient of 35. If you do a DVI of 0.25, which is pretty easy to remember, because if you do a dimensionless index of the aortic valve, 0.25 is the cutoff for severe, so that's kind of an easy thing to remember. Effective orifice area of 0.8, so it's probably stenosis if you got an EOA of 0.8, and you can look at your acceleration time. And if it's greater than 100, then it's significant for stenosis in the aortic valve area. So mitral valve, you can do the same thing. You can shoot a Doppler through there. You can get a peak velocity. If it's greater than 2.5, then it's severe. Mean gradient of greater than 10 is severe, and et cetera. You can look at the rest of this. I wasn't going to talk about pressure recovery. This is an older slide, but I'll just touch on it really quickly. This is a thing that might come up on your boards. So the idea of pressure recovery is that over here you have this large amount of potential energy, and after systole, all the flow goes through here, and it gets converted to kinetic energy. And out here in the ascending aorta, it recovers some of the potential energy back here. So how we calculate gradients is different from when you're in the cath lab and you calculate gradients. So what the cath lab cardiologists do is that they have a catheter over here, and it's measuring what the peak velocity is in the LV, and then they pull it through and see what the pressure is. Sorry, the pressure over here and the pressure over to here, and that's called the peak-to-peak gradient. And that's different from what we're doing, which is continuous wave Doppler, and we're checking velocities all along here. So mainly what we're catching is over here, and this is mainly for patients who are getting bileaflet valves, and typically in smaller people, in which you have a large amount of pressure gradient here. So your pressure gradient will be much higher than what they get, and what we're measuring is what we call peak instantaneous gradient, and what they're measuring is peak-to-peak gradient, so that's a little different. So that's the phenomenon of pressure recovery. Okay, so like I said before, ultrasound doesn't penetrate metallic or polymeric components of the bioprosthetic and mechanical valves. So that makes it difficult for us. So that's why we have to take our time, look at things in different views and different angles. Okay, so this is a real case that I did. This is a patient that had a mechanical valve that was placed a while back. Came back because had a diagnosis of a ascending aneurysm. So the surgeon asked us, is this valve okay? Do I need to do anything with it? So we put down the echo, we get our views. So there is, obviously this is abnormal, right? This ascending aneurysm looks big. So we'll look at the valve and tell him, if we think that he needs to do something about it. So we'll look at it. This is the mid-esophageal long axis view in 125 degrees. And we put color on, color off, and looked okay. It didn't look like there was any paravalvular leaks that were pathologic. The valve leaflets looked like they were moving okay in the short axis, so that looked okay. We didn't see any masses or anything like that. That looked abnormal. One thing that I want to point out is that, do you know what this number is over here? So this is the frame rate, right? It's 75. And why is the frame rate bigger over there than it is over here? And that's because the sector width is a lot bigger here than it is over here, right? So whenever you are decreasing your sector width, you're increasing your frame rate and therefore increasing your temporal resolution. So just keep that in mind when whenever you're imaging something that's moving very quickly, if you decrease your sector width, then you can see things move in time, and that's what temporal resolution is. So anyway, so with aortic valves, make sure you look at things in different views and different angles, right? So you have the deep transgastric short axis, so this is 0 degrees all the way in the stomach. You're going to have your aortic valve over here. You have your mitral valve over here. And you can see that there's much less shadowing over here, right? Because the sound waves are coming from up here, and they're traveling down over here in a line, right? So that's pretty much how echocardiography works, is that these are basically scan lines over here, or M mode, and it's a bunch of M modes that are just stitched together. So because of that, you're not getting any shadowing until you hit over here. So you can see all the LV over here. And over here, it looks like that there's some regurgitation, but since that's coming from inside of the ring, it's likely to be, or most likely to be, a washing jet. Over there, so it's being okay, so you see that? So you got some washing jets over here, it's coming from inside of the ring. So far it looks okay, right? So we told that to the surgeon. We are gonna ask ourselves, is the valve well seated? Looks okay, the leaflets are moving, opening and closing okay. The mass on the sewing ring, there is no mass, looks like it's okay there. Looks like there's transvalvular regurgitations coming from inside of the ring and not outside, so it's likely to be a normal washing jet with a mechanical valve. Prosthetic valve stenosis, ideally you put a Doppler through there and say that it's normal or abnormal. It was okay. And are there other cardiac structures? So far, looks like everything is okay except for ascending aortic aneurysm. So we told him that was okay. So we opened it up, told us after all of that, we did an ascending, he did this part, look down here, it looks okay, we're opening and closing okay, great. So we left the valve alone and we closed him up and he did very well. So finally, I'll just show you a couple of pictures that look, so abnormal pictures. This is a case that I did also. This is severe aortic stenosis with a native valve. Your pressure gradient is 46. Your max pressure gradient is 77, so that's severe. Keep in mind when you're doing a Doppler measurement, try to be as parallel as you can to flow, because the Doppler equation, if you are off by a little bit, you're multiplying everything by cosine theta, right, your angles, so keep that in mind. And this is a Percival valve that we place. So you see all this like metal alloy over here, that's gonna cause all this reflection down here. So that's what causes it to be a little more difficult, especially in the aortic position, to image these valves, although you can kind of make out that these are the leaflets here, but it's hard to say so, right? You could put color in the short axis and look for a leak. Look, there's a lot of color flow in the middle here, suggesting that there is something abnormal going on. And in the deep transgastric, you can see this is likely the middle of, this is the valve itself, but from the outside, there's some leak over here that is the bigger one, and there's probably a little whiff over here of a jet that's a paravalvular leak. So it's important to look for these things in different views, okay? So a few tips on imaging these valves. So this is another important slide. So there's only 2 important slides. So if you paid attention for about 1 minute, 30 seconds for that first slide, 30 seconds for this second slide, then that's pretty much my entire talk. So decrease your depth to show only the object of interest. So why do you do that? So you do that in order to improve your axial resolution, right? So you want to do that so you can tell objects that are in front of each other that they're 2 different ones instead of the same thing. Second thing you have to do, especially when you have like endocarditis that you're worried about, or thrombi, sometimes it's hard to see them because they're moving around really quickly. So if you zoom in and take your time and use your slow-mo functions, you can see that you may increase your chance of seeing them better. Decrease your sector width, like I said before, sometimes that helps. The only thing with that is that you have to be right under right in front. Your object of interest has to be right below. If it's on to the side, then it's going to be difficult to see it with decreased sector width. And finally, you image your valve in multiple views and angles. Okay, thank you.